Okay, let's talk about normal resting cardiac pressures. Pulmonary capillary wedge pressure, also known as PCWP, in MMAG is a good approximate of left atrial pressure. And the question is, why is that? Why do we, when we want to look at the left atrial pressure, let's just draw the heart. We want to look at left atrial pressure here. Why can't we just directly look at the left atrial pressure and we say, okay, PCWP, which is the pulmonary capillary wedge pressure, is about equal to your left atrial pressure? Why? Because if you recall, we don't have any catheter that goes into the left atrium until or unless we break a place here, which is called foramen ovale. So just guess what? You want to look at the pressure of the left atrium, and for that you wanna open up the foramen ovale to see the pressure. That's not right? So you wanna have something else for that. So what you do is you put the catheter from the veins into the IVC to the right atrium, then goes into the right ventricle. From right ventricle goes to the pulmonary arteries, and from pulmonary artery you want to go to very smallest artery that you can go into, or in fact pulmonary vessel, you want to go into the smallest vessel that you can get into, that the catheter can move into, and you check that pressure, whatever is the pressure, because eventually that same pressure is going to go where? From the pulmonary vein, it's going to go open up into the left atrium. So whatever this pressure is, we call it PCWP, pulmonary capillary wedge pressure, and we say it is approximately equal to left atrial pressure, because it is easier to, it is not easier, but I mean, you don't want to break up anything to go into left atrium, right? You don't want to make a hole through it in order to go to left atrium. So let's read what the book has to say. It's a good approximate. So PCWP is a good approximate of left atrial pressure, except in mitral stenosis. In mitral stenosis, why not? Because you already have a mitral stenosis here. Guess what's going to happen? You have increase in left atrial pressure. So no matter what your PCWP is, it's not going to equal your left atrial pressure, because all the fluid is just here and it has increased the left atrial pressure. So it is not a good approximate in the mitral stenosis, in which case you have when PCWP is greater than the left ventricular and diastolic pressure. PCWP is measured with pulmonary. Here you go, that's what I was talking about, right? So PCWP is measured with pulmonary artery catheter, Swan-Ganz catheter, pulmonary artery catheter. Again, same way, you put the catheter in, go to the pulmonary vessels, and try to get the smallest, from the smallest capillary, the pressure, and that pressure is equivalent to your equivalent to your left atrial pressure. So that is one thing. Now let's look at the normal pressures, high yield. What are the normal pressures? So normal pressures in the superior vena cava or inferior vena cava, superior vena cava, or even the right atrium, the pressure is going to be less than 5. Okay, in your right ventricle, the pressure is going to be 25 to less than 5. Okay, and when you go into the pulmonary artery and then pulmonary vessels, the pressure is going to be less than 25 to 8. And PCWP is going to be about 4 to 12. 4 to 12. And then when you go 4 to 12, right? So again, when you get back these vessels back into the left atrium, the pressure has to be less. And the pressure normally, we're talking about normal here, the normal pressure is going to be less than 12 in the left atrium. For the left ventricle, the pressure is going to be so systolic and diastolic, right? So systolic less than, I mean, just 120, but the diastolic less than 12. And but as soon as that pressure goes into the aorta, that pressure, the diastolic even becomes 80. So 120 by 80. So what is the way to memorize this? So the memorization is easy. So just remember. So we are just trying to increase the pressures, right? So less than 5, we're just giving a systolic pressure to the contraction. When you contract, we give a pressure. That contraction pressure becomes 25, or as you might see somewhere else, it will be equal to about 30. Okay, so 30 to this 5 is less than 6, so less than 6 you can call less than 6. Okay, and this is from another resource. Just remember 5. I think 5 is easier to memorize than memorizing 6 as the normal temperature. So 5 is a good way to go for. So less than 5, less than 5, 25, and 25 and less than 5, right? And then the same 25 goes, because now you're contracting again, the same goes there, it becomes 25. But here, there, they become, again, you can call it 8, or you just call it less than 5. Same thing, almost the same thing, because nobody's going to check on that. I mean, you wouldn't, not important. What is important? Okay, just remember the diastolic we are looking at. Diastolic we are looking at -5 till about pulmonary pulmonary vessels. But as soon as we go to the left side, we're going to call that diastolic 12, less than 12. So left atrium less than 12, left ventricle less than 12, and but as soon as we go to aorta, we're going to call 80 as the minimum diastolic pressure. Uh, okay, and then aorta, we not only have diastolic pressure 80, but the systolic is about 120. So 120 is when you contract the left ventricle, you're giving 120 pressure. So maybe any way that you can memorize these pressures, high yield. But just to go through, you're looking at 5, you're looking at 25, 5, and then you're looking at 25, 5, looking at less than 12, less than 12, and by 120, and then 120 by 80. Okay, so that's all for the normal cardiac, normal resting cardiac pressures. Now let's look at autoregulation. In autoregulation, what do we have? We have how the blood flow to an organ remains constant over the wide range of perfusion pressures. You know that perfusion pressure, which equals to the systolic blood pressure minus diastolic blood pressure, is not always same. But how do we have the constant blood flow to the organs? Well, that is due to the fact that we have autoregulation. What is autoregulation? The autoregulation is in these organs, which is in the lungs. What is the autoregulation of the lung? It is the hypoxia causing vasoconstriction. As you know, one of the important thing is in the lungs, the hypoxia was called vasoconstriction, but in all the rest of the body, the hypoxia causes vasodilation. Okay, so but in hypoxia, and why is that? Because when, let's say you have hypoxia, that means you are not getting any O2. You don't need to send blood into the place where you're not getting O2, for sure not. But in other words, in the rest of the human body, what do we have? When we have low O2, the vessels, they dilate. Why? Because whatever is there, they want that O2 to go into the organs. That's why they vasodilate. Here, we don't want to go into shunting, meaning the blood, we don't want the blood to not just go and not get oxygenated. So we shift that blood and we shift it somewhere else where there is oxygen coming in the pulmonary circulation. Okay, so this is for the lungs autoregulation. The pulmonary vasculature, let's read this thing. The pulmonary vasculature is unique that in the alveolar hypoxia causes vasoconstriction, so that only well-ventilated areas are perfused. In other organs, hypoxia causes vasodilation. This is exactly what I just explained. Okay, next one is heart. The heart is the local metabolite vasodilators are your nitric oxide, your carbon dioxide, your low oxygen. So when you have these vasodilators in the heart, what it's going to do is they will cause the release of local metabolites. And those local metabolites will maintain the constant blood flow in cases of wherever there is a change in the perfusion pressure. In the brain, what do we have? Again, local metabolites, vasodilatory, which are your carbon dioxide specifically, or the pH. And the pH as you increase the carbon dioxide, you decrease the pH because CO2 is acidic. In the kidneys, we have myogenic response and tubuloglomerular feedback, two things. Myogenic depends upon stretch-dependent response of the efferent arterioles, and there is a tubo, and we will see these two things in the kidney, how they work and cause the change in blood pressure. Skeletal muscles, local metabolite during exercise or vasodilators. In skeletal muscles, when you exercise, you have the vasodilators, for example, chalk. You have carbon dioxide, hydrogen ions, adenosine is the new one now here, right? Adenosine, lactate, and potassium even. So chalk is a very good mnemonic. So these are local metabolite for skeletal muscle, which is carbon dioxide, chalk, carbon dioxide, hydrogen ions, adenosine, and lactate and potassium. At rest, the sympathetic tone in arteries. At rest, you're just looking at sympathetic tone in the artery. Skin, sympathetic vasoconstriction, most important mechanism for temperature control. So again, what is skin doing? Sympathetic vasoconstriction for the temperature control. And these are all the autoregulation. Important thing in this autoregulation is just these metabolites. So what are such metabolites? Nitric oxide, CO2, and low oxygen in heart. In brain, you're just looking at CO2. In skeletal muscle, you're looking at all the chalk, which is CO2, hydrogen, adenosine, lactate, potassium. And also very high yield is this hypoxia causing vasoconstriction within the lungs. And that is all for the autoregulation.